My name is Pamela King, and I am the HIE Outreach Coordinator here at the Agency for Healthcare Administration. And we are doing a virtual panel today, a little bit different format than we normally do for our webinars. And we have some very impressive folks here with us on the call today. I do want to let you know, as participants in this meeting or in this presentation, we're trying to answer questions that you have about what's on the horizon for health IT. And so if you have a question, there is a little hand in your right-hand corner, it should be, and you can just click on that hand button, and I have Carrie Gaudio on the call with us, and she will unmute your line so you can ask your question as we move through our conversation with our panelists today. Or you can go to the question box, type in your question. If you don't like your voice to be heard online, just go and type your question in, and we'll answer your question as we move forward, and Carrie's going to help us with that. Thank you, Carrie. So today we have with us Heidi Fox, and she is the administrator here at the Florida Center for Health Information Transparency, works with me here at AHCA, and she's actually responsible for the Health Information Exchange Program as well as our Electronic Health Record Medicaid Incentive Program, as well as a lot of other activities that she does here in Florida. Has a wealth of knowledge about health information technology, Medicaid, all kinds of wonderful information that we can pull out of her today as we move forward. We also have Mr. Jason Mcnamara. Some of you may know Jason from his work with the Center for Medicare and Medicaid Services. As you can see from his bio that's up here right now, he's got a great sense of humor. I too wish for a world where wine and scotch didn't add inches to my waistline. So something me and Jason have in common. He now works with Audacious Inquiries and does some great work with them in helping build the infrastructure for health information exchange, both nationally and some work here in Florida. We also, last but definitely not least, we have Dr. Philip Smith. Dr. Smith is the president of MedMorph. I told him he could shamelessly plug some of the wonderful things he's got going on right now, but one of them is he has authored a book called MedRec. And it is downloadable, free, and it has some solutions on how we can deal with Medicaid reconciliation. So Dr. Phil, as he is lovingly known, is a former Chief Medical Information Officer at H. Lee Moffitt Cancer and Research Institute here in Florida, and has been working with electronic medical record systems and health information exchange systems well, he's too young for the beginning of time, but for a long time. So welcome all of you to our conversation here today. I'm so excited to have you all here. I am going to get the audience warmed up. I'm going to ask a few questions myself, and then we're going to open it up to the audience and see what questions are out there. So this should be exciting. No telling what questions we're going to get asked today. I'm going to start, Dr. Phil, I'm going to start with you because you've been around for a little while. And so the first question I have is, why do you think information technology, IT adoption, has been so slow in healthcare compared with other industries?
Yeah, thank you, Pam, and thanks to everyone participating today. I love the opportunity to answer your questions. And I want you to know that I adopted an electronic medical record in my office in Newport Richey, Florida back in 1993. So I've been doing this, I like what you said, Pam, since the beginning of time when dinosaurs ruled the earth, long before meaningful use, and have been really specializing in EMR adoption over the last 20 years. And I always like to start by defining what EMR adoption is and IT technology adoption is, because there has been a lot of health IT that has been implemented, but adoption has not been as widespread as the implementation has. And I was talking to a group of family physicians last weekend, and you know, they were very frustrated that over 80% of physicians who have an electronic medical record report that they are very dissatisfied with what they've had implemented and really have not adopted it. And often I go into hospitals and offices where they say they've adopted, and then I find that they really aren't using the technology the way to really leverage it. So I think that meaningful use has accelerated the implementation of health IT, but adoption is lagging because people really have not seen the value that they would want to see. And as a physician, I always say there's only three things I'm interested in: time, money, and peace of mind. And so an EMR has to, and let's focus on EMRs for a minute. EMRs, for instance, should save me time and make myself and my staff more efficient. It should help me to be more profitable. That's the money part, and not cost me more than I can benefit from it. And there are many incentive programs now that help to offset some of the costs. And I would say that there's many changes in healthcare that if we don't adopt health IT, we're never going to meet our goals, and we're going to start losing revenue. And that's really critical. And the third is engineering health IT to improve patient safety. So I think we're going to see a shift in what we think of health IT is in the next 10 years. And I think we're going to be moving to a more empowered and enabled patient through remote monitoring, through telehealth, and through use of consumer data to improve healthcare. So I'm encouraged. It's amazing sitting here 24 years after I implemented my EMR to see how slow it's been adopted, but I feel like we're at a tipping point, yet we still have some challenges to overcome.
And building off of that, Jason, what are your thoughts on, I mean, Dr. Phil mentioned that time, money, and peace of mind. What are your thoughts on how that health information technology can start being adopted? What are the things that we can do to help increase the use of health information technology?
You know, I think that the good doctor is right. We are at a tipping point, but it's important to remember that we had folks that were implementing technology decades ago, but it hasn't been until recent years where we've had actual market penetration and saturation of the technology. And I think what we're experiencing now, to the doctor's point, is we're testing the validity of the systems that we're using, and we're also testing our internal processes and workflows through this change. And so I think continuing to have the conversation and continuing to push our vendors, but also understanding what we actually need. And I think what we're seeing as a way forward are these microservices, if you will, instead of these large full turnkey solutions, but providing specific needs with specific data elements at a specific time. I think is something that we'll continue to see. And as we're seeing with the policy that's coming out of Washington, D.C., and both at the state level, the policy, not the health IT policy, just the healthcare policy, is now requiring the use of electronic data and systems. And so as those policies mature, that they'll continue to be a driver in these programs. Meaningful Use did have a place to sort of jumpstart the industry, but we're seeing the policy really drive a lot of these conversations, and the reimbursement policies that are coming through on the commercial side. We're seeing a lot of the commercial payers reinvent their processes and contracts with providers, ensuring that they're running these microservices or these health IT adoption standards. So it's an interesting time.
Yeah, it is a very interesting time. We're seeing things change. And Heidi, I know in Florida, I'm going to go back to Jason's comment about focusing on the specific needs and those microservices or the needs that are determined by the market and what's being used. And so what here in Florida, what services here in Florida are we seeing as an increased use in, or the area that we're seeing more growth in as far as health information exchange goes?
Mm-hmm. So we have the event notification service that we use with health plans and ACOs, and I think that's been a very valuable service to them to be able to get alerts when their patient is in the hospital or discharged or in the emergency department, and that really helps them manage care and know about activities that are occurring in real time. We have a lot of subscribers that are accountable care organizations, and I guess they count as a newer payment model. I guess they're about 5 years old, and it really is so symbiotic with what they need to do. I think the interface between the health plan model of care and the clinical providers, there's a lot of opportunity there to provide information, back and forth, information that health plans have on the social determinant side with the clinical side, and make a more seamless connection between those two sides of patient care.
And that really kind of goes to what Dr. Phil was talking about initially, that time, money, and peace of mind. And actually what Jason had said too is like, where are we going with services, and are we focusing on those things that the providers and the healthcare industry is looking for? So it's really exciting to see things like that coming out. And
yeah.
Jason.
There was such a flurry to Jason's point, of development, and the market. When we first launched the Meaningful Use program for Medicaid and Medicare, there were so many products on the market, so many options, so many choices, and they were required to do sort of a particular menu of activities. And I think now that the program has matured and we've rolled along with it, there's a lot of demand on the provider side to do specific things and do those things really well. And I think that those technologies will start to shift to meet that demand a little better.
Do either of our other panelists have any want to add to that, to what Heidi just said?
Well, I think Heidi's exactly right. And when we looked at meaningful use, for instance, in stage 2, one of the things was health systems had to be able to transmit information using secure email, they're called direct email accounts, but yet it did not require anyone to be able to receive them, which was kind of a ludicrous thought, that all this effort to create infrastructure to send messages that no one can receive. And I think meaningful use is now coming to the point where the maturity is happening and people are saying, no, let's not just check off things that need to be done. Let's close the loop on things, and let's make information more fluid. And we like to refer to interoperability, but we really want to probably talk more about Heidi's role, which is transparency. We want people to make decisions with all the information that's going to be relevant. And we need to remove barriers that trap information in a way that it can't be used by other people.
Well, and to Dr. Phil's point, Jason, do you think we are going to ever have true interoperability, or that transparency that he referred to?
Yeah, so that's the million-dollar question, right? That's
yeah.
Always in the news, and it's always in conversations. Just to level set, right? There's a couple of things to visit around interoperability. Interoperability is not a singular thing. If you actually break out interoperability, there's sort of 4 components to it. And so there's the idea of transport interoperability, and that's really focused on how you're moving the data. Excuse me. And then there's messaging or document interoperability, and that's really leveraging the payload of a specific data set. And then the semantic piece, which is actually the vocabulary around interoperability, things like ICD-10, SNOMED, stuff like that. Even if you break down the semantic pieces of interoperability, those vocabulary dictionaries are massive. My favorite analogy to this is temperature. If you actually look up and map all of the different vocabulary definitions of temperature, there's around 1,600 in the healthcare space, right? So the semantic piece of interoperability is crucial. And the last mile plumbing, if you will, is really about process interoperability. To Dr. Phil's point earlier about getting into the workflow and understanding the needs and helping with efficiencies and time. That's the tough part because that's largely manual resources that are focusing on understanding the critical problems and connecting those problems to the utilization of technology, and meanwhile not disrupting care, right? And so when we break apart interoperability from those four segments, you can see certain progressions evolve with the different interoperability areas. Interoperability to me, just my personal experiences working tactically with technology systems, is really sort of a North Star journey. It's something that we continue to talk about, we continue to inch towards, but the last part of interoperability, this process integration, changes over time. And so because that's changing and that's dynamic, we'll always be talking about interoperability. We have a long way to go still on some of the transporting and the document standards and the semantic pieces of the vocabulary and interoperability. But even once those are really figured out, we'll still end up with that last mile plumbing challenge, which is we're working with people every day. And those people have different needs at different times, and those things evolve. And worked yesterday, to Heidi's point, the Meaningful Use program at the start required a number of different things from a number of different providers, and that's changed now. And we fast forward 7 years now, and that program looks vastly different because the program's matured, people understand their technology a little differently. And so I think interoperability will be something that we always work towards, in my opinion.
Yeah, and I want to add the reason I wrote the book MedRec, and that's spelled W-R-E-C-K, was because I think we need a moonshot to help us better understand interoperability. And what I propose in that book is that we create a national infrastructure just for the purpose of the payload of medication histories, so that we have a laboratory where we can actually learn how to get to a single source of truth in healthcare of a data point that's very important, which is what medications patients are taking and what are you on at any point in time, because we spend the equivalent of 32,000 FTEs a year in the United States doing medication reconciliation, and yet we still have large numbers of patients harmed each year from medication errors. So I actually threw that book out there for the general purpose of getting a different discussion about interoperability around medication safety.
Dr. Phil, that sounds like an awesome idea, and embedded in that you would have to have some kind of patient identifier, which I think would go pretty far to facilitating the exchange of health information. That's certainly one of the barriers that we've encountered in Florida. Is being
Yeah, and I was recently talking to someone from the country of the Azores, which I didn't know where that was. It's off the coast of Portugal. And they actually, every person in their population has a biometrically obtained health information smart card with their photo. It looks much like a modern day credit card with the chip in it. And it stores a certain amount of health information. It has their photo on it, and they get it through a biometric authentication process, and creates an individual identifier that they use every time they have a healthcare encounter for both receiving healthcare, adjudicating healthcare, and confirming who the patient is. So we definitely, and that's one thing I lay out in the book, that we need to have some type of way to get a national patient identifier. And I think going for medication safety would be a great starting point.
And I do have a question on patients, but before I get to that, I think we have some questions from the audience. So I want to make sure we give a chance to get some of these questions in. Carrie, do we have some questions?
Yeah, Pam, we have some great comments from Jean commenting on the difficulty of small and medium-sized clinics in adopting HIE and how there's a real need for clear and specific roadmaps for those smaller providers, and then also by provider type. And it's going to be different for everyone. So she was commenting on those things, and maybe the panelists have some additional comments on that.
This is Dr. Phil. I'll take that. Personally, I think about the statistics. 80% of small practices are very unhappy with the level of implementation of electronic medical records in their office. To me, that is something that needs to be overcome, and that being able to leverage the HIE would be one of the value adds that a small practice would have. However, they have barriers in that oftentimes the implementations have been poorly done, and there's not been good buy-in and training and automation of workflow to actually get efficiency. And it's a shame because in '93, I was able to cut 2 to 3 hours a day off my daily time I spent doing medical documentation, and literally would leave the office with all my work done at the same time the last patient was checking out. My schedule ran more on time, and my patients were happier, and I ended up paying for my system in my first year and making a profit. And I got a lot of feedback from pharmacists because they could read my prescriptions in a day when everyone else's were handwritten. And today we have e-prescribing. So I think the meaningful use data from 2015, I haven't seen the 2016, said that 66% of providers were at stage 2 meaningful use. So we still have about a third of providers who don't have any EMR, but that should not be a barrier to them using an HIE, but having that integrated into an electronic medical record makes the HIE more useful. But I think we have to overcome the doctor's experience and attitudes towards health IT by giving them a better experience, and some of that just requires, in fact, I just started yesterday a new 12-part series on optimizing office EMRs, and that'll start to be available starting next Tuesday on my website. So I think that's our starting point, is we've got to get doctors more engaged with using technology in their office.
So do you think it's the systems that are out there, or is it the users, or is it a combination of both?
There's an old saying that attitudes determine your altitudes, and I think any EMR can work. I think most people implementing office EMRs in small practices don't really understand small practices. And my evidence for that is the 80% that are dissatisfied 24 years after I had a very satisfying experience. I think it's, in most cases, when I've gone in and worked with people with their EMR, it's almost never the EMR that's the barrier. It's their use of it. And as Jason said, it's a mismatch between how you could be doing your work and how you're actually leveraging it. And so EMR implementation should be about automating workflow to maximum efficiency and patient safety, and the goal should not be implementing the EMR. It should be leveraging the EMR and empowering everyone in the office to be more efficient, patients to be safer, and make the practice more productive.
Which is really the hardest part.
Yeah, it's hard, but it is not impossible. And I was at a health system, fairly large health system, that had an EMR for 8 years that nobody had adopted. And 2 years later, they were at HIMSS level 6, which is pretty fully adopted. So it wasn't because we took out the EMR and gave them a different one. It's we leveraged the EMR they had that had been poorly deployed.
There seems to have been a bit of a culture change in practices. When I go in to go to a doctor's visit now, when they hand you paper or ask you to do anything on paper, there's like an apology that comes with that. So I think they realize that there's an expectation that this experience needs to be automated. It's just that last mile of getting people to actually change their workflows. That's the challenge.
Yeah, 5 years ago we were talking about how we never saw bank tellers when we use the ATM. Today you use your smartphone to do your banking, not even the ATM. So, I mean, other industries have moved on, but we're still stuck in trying to automate the old way of doing things rather than leveraging the automation to do things in a new way.
Jason, would you like to add anything to the conversation? Your name got invoked by Dr. Phil, so.
No, I mean, I agree both. I couldn't agree more. I mean, I think the smaller practices, have this dissatisfaction because they're stretched thin, and there's a lot of opportunities for communal solutions like HIE services to provide some support in areas that we know smaller groups suffer on, and things like being able to effectively communicate across a community and a continuum of providers based on providers that are interacting with their patients, and especially those 1 to 3 provider practices that are very limited in resources. And we've all interacted with those practices before, but it's the typical scenario where there's the practitioner, and maybe there's a mid-level, and then maybe there's a family member that's acting as the practice manager and helping with the administrative functions, and they outsource their IT infrastructure to their neighbor who's really excited about IT. And there's all those kinds of nuances that community efforts can really help close the gap on. So I just concur with you both.
Wonderful. Did we have any other questions, Carrie, from the audience this time? Any hands raised? And just a reminder to the audience, if you would like to speak, just raise your hand and we will unmute you so you can ask your question. Otherwise, you can type that question in our question panel. So, Carrie, did we have anything else?
Some additional comments about getting smaller practices to kind of adopt the culture and accept the necessity to implement IT and the difficulty around convincing smaller providers to accept that next step.
Yeah, I think that the panel has covered that. I mean, you really can't change attitude. You can provide information, is what I've heard our panelists saying. Speaking of that, though, as I go to my doctor, and she is a younger woman, and so I go in, I see my doctor, I leave, and I used to leave with pieces of paper all over the place that I would lose, and today I leave with nothing in my hand. As we, this is a question I'll start with you, Jason, as the youngest member of our panel, but as our baby boomer physicians start to retire, what do you think that the younger physicians out there are going to be more willing to use health IT in their practices?
I mean, the short answer is yes. I have the fortunate task of working with executive master students in DC, and through that cohort come a lot of doctors and PhD types. And there's a clear distinction between the older generation of providers and that younger generation of providers. Expectation from the younger generation that technology be part of the equation. Some of my work prior to CMS, I was working with the VA and DoD, and one of the VA sites that I was working with was a teaching hospital, and all of the students were always looking forward to interacting with the VA's electronic medical record because that was their first introduction to an electronic health record system. And they take that knowledge and experience out into the market. And as they continue into their residency and as they continue to find their home as a provider, there is that expectation. I've talked to some providers who are on the verge of retirement, and they may not have adopted electronic health record, but what's interesting is that the younger generations that are buying their practices require that they have some sort of subsidy or some sort of offset because they haven't adopted electronic health record. And so there's some of the later generation of providers that are adopting just for the purposes of selling their practice. So we're in this climate shift, right? This is a climate shift that I think we all experience. You know, as a young child, I didn't have technology. Now my nephews and my son, it's part of their everyday life. And so I think we'll see that trend to carry over into the healthcare space.
One of the things that Dr. Phil said that was pretty interesting was, you know, adapting your workflows to the technology, not trying to use technology to recreate the workflow electronically. And I wonder if either of you have seen any great examples of how that is. And, you know, med students kind of cutting their teeth on technology, maybe going into their practices with a different approach to the workflow. But I'm hearing the opposite thing. What do you have to say?
I was recently at a very rural area of Missouri about a month ago, and there was a couple things. One, to build on what Jason said, the hospital told me that they cannot recruit doctors into their county unless there's an electronic medical record to be used, because the graduates have never worked on a paper record, and they can't compete if they don't have an electronic medical record. So they have to actually provide records to even the doctors who don't go to the hospital, because many doctors now want to go into an own practice and not start at hang a shingle like I did. The second thing is, in that same community, I observed a family physician who was leveraging the EMR in a way I'd never seen before and pulling together. She had actually had someone do some custom programming to create an entirely new module within their electronic medical record, and they were in the process of replacing with a different vendor. And the workflow that they had custom programmed on this older model was not something they were going to be able to easily do on the new system. And I was very intrigued, having been in the field as long as I have, to see someone who had actually invented a completely new workflow. And it was leveraging problems from prior visits and pulling forth the last time she had dealt with that particular problem. And she would literally pull together the last 9, she had a little grid of the last 9 visits for every patient, broken up into modules, and she would select with point and click a paragraph from each of the on each of the topics that she was covering today based on the information from the last time she saw the patient for that particular problem. Very innovative. It's exactly the type of thinking that is so much needed in healthcare, to not spend a lot of time trying to review records and to leveraging what's available, whether it's in the HIE or in your own chart. She was pulling information from multiple sources and leveraging that to make sure she had an up-to-date documentation of what she was actually doing for the patient and the problems that she was dealing with on these very complex patients with more than one disease that they were treating.
That's very interesting, very innovative. I see that we do have a question, another question from the audience. We have a audience member that wants to know how data from wearable devices fits into the future of health IT.
Well, this is Dr. Phil. I'll tackle that. Up until about a year ago, the wearable device data was not really getting into the EMR. It was having to be recopied, and now there's more of a drive that the data is collected and actually assimilated into the data of the electronic medical record. So now, and I'll speak of Cerner and Epic, both Cerner and Epic has the ability to accept data. Now, you don't just put the data directly into the EMR and alert the doctor of what's going on. You have to put a call center between that so that you have the data coming in. You have a team that monitors the remote patient monitoring data, but the data itself flows into the electronic medical record and then can be re-leveraged when the doctor sees the patient or gets a phone call of the patient. They can leverage that data directly as structured data within their documentation of that visit. So we no longer have the days where back in the early 90s, if I wanted the patient's blood sugars, for instance, in the chart, I would have to look at their paper log of what they have and kind of make some comments in my EMR note of what those results were. But today, you can literally copy those results that have been imported into the EMR and just include those into the note so that you can trend them and summarize them. So that's a major advance, and it creates more transparency. And we did something like that at Moffitt, where we had patient completed surveys that they did in their waiting room on well-being, how they were feeling. So in cancer care, it's very important that you know how's their appetite, how's their sleep, how's their mood, how's their sexual activity, all the things that are important to the patient, and we were able to have them fill that out on an iPad in the exam room. And then when the doctor opened the chart, those results were actually there and showing trends of where they were in the past, and created to clinical decision support to alert you if the patient was deteriorating on those measures and needed interventions, and could literally create automated consults to patients that are having high levels of distress. So those are all examples of what you can do when you start getting structured data, both patient collected in the home and patient reported even in the waiting room. And we need to move beyond those endless clipboard fill in the blank of, checklists that we do in the office, and to automate those and make them interactive in the electronic record workflow.
And Jason and Heidi, I want to bring you guys into this conversation about consumers, the patients, and the role that they play in Help IT. And so, what do you guys? I'll start with Jason. And what do you think the role of the patient is as far as Help IT and Help IT used by providers? And then I'll follow up with Heidi on, you can even answer this too, what do you think that the consumer's expectation is regarding health information technology and healthcare in general? So Jason, we'll start with you. I asked about 10 questions, so pick the one you like.
Yeah. So I think I'll actually answer the last one first. I think the job for us as consumers and as patients is to become educated on what it means to have health information technology be part of our healthcare system. I think there's a lot of misunderstanding from a consumer's perspective about what technology is or isn't, and where it helps, and what it's actually doing. And so from a consumer perspective, we have a responsibility that's collective to educate ourselves about what the technology actually is. And I'm not talking about learning how to code or anything of technology. And as we continue to mature that, finding ways to connect the consumers and the patients to the systems in a meaningful way. And I'll speak about something as a classic example of that. If you are a caregiver for your mom and you are monitoring all of her social needs and her healthcare needs, and you go out of town, having a process to connect to your mother in a way that you understand what's happening to her is crucial to your peace of mind. Going back to the good doctor's comment earlier, there are methods out there that already exist in the marketplace. The Florida Notification Service is a classic example of this, where notification,
Jason, we're having a little bit of trouble hearing you.
Sorry about that. Hear me now?
Yes, we can.
Okay, perfect. Yes, like the Florida Notification Service is a classic example of how you could actually open that up to a caregiver, and so you could get it to the hospital. So there's services like that, these microservices, this peace of mind for the consumer. I think the challenge becomes, a consumer has multiple providers for different reasons, and depending increases or decreases the amount of providers that you interact with, but not every provider can have a patient portal. Not every provider can have these siloed technology, and so this is where health information exchange has an opportunity to aggregate some of the consumer data, be able to present that back out to the consumers in a meaningful way. So we see this as a trend. You look at, for example, clinical portal utilization, which is providing patients access to their clinical data. That number is relatively really low, and it's low around the country. It's not just low in a specific region. And the hypothesis is that it's low, A, because the data is not always complete, and B, there's a lot of misunderstanding to the earlier comment about what the role is of that data and what the role is of that technology. So I think we have a long way to go from a consumer perspective. Coming back to my earlier comments is that...
I think we might have lost you. Okay, that means I'm going to Heidi.
Well,
what are your...
I think consumers have to carry the torch of the vision of going into a provider's office or having, healthcare provided in a fully automated environment. I think, to Jason's point, PHRs are such a great idea, and I wanted to be a really fervent, really faithful adopter, but I got one from my health plan, I got one from the dermatologist, and one from the ENT, and they were provided by the same vendor, but they were different logons. I couldn't figure out how to integrate them. I went after an accident and had a tetanus shot, and then that didn't show up in my health plan EMR, even though they'd paid the claim. And it was just that disconnect of all that patient information needs to get improved. And I think consumers really, really, really want that to happen and are going to be adopters of that as soon as the information improves, and they're rewarded when they go out there and see their lab result and see their x-ray and see their tetanus shot and all their meds and all that. And I think that the expectation is that you don't go and get asked for your demographics again and you to cough up your med list when you're 85 years old and you have it written on a little piece of paper in your purse, that all of that is there for you. And I think that consumers are expecting that, and they will hold forth with that expectation.
Okay. Let's see. There were some more questions from the audience.
Yeah, Pam, we do have some good questions in here. How can HIE and HIT take the social determinants of health into account?
Heidi, you want to take that one?
Oh goodness. I would have to give that one some thought. So I think that, being able to do like mHealth, is that mobile health on your phone? So I think that the access to that kind of information about your healthcare and that ability to make appointments and that ability to be reminded, and from a consumer perspective, the social determinants don't really, to some extent, it's a democratizing modality to be able to get all this information on your cell phone. So you're back, Jason.
Yeah, I'll jump in here. So, and I'll talk about some use cases that are actually happening around the country. So, social determinants of health are an interesting conversation because it's really hard to quantify sometimes. And like anything else, what's the definition of that, and what attributes are we going to actually surface as a result of that? But let's just take a couple of things that I think matter to practitioners. So social services, right? If we know that we have a specific patient population that is engaged pretty heavily in the social services section, which is things like food, housing, maybe electricity subsidies, transportation, things of that sort. There are governments out there, and there are county level, state level, that are exposing that data and providing it out to the care community. And what you can use is that specific trigger from a given patient and leverage that to incorporate the social determinant data at the point of that trigger. So imagine that you're an ER doctor and you've just now taken in a patient that has chest pain. And it turns out this patient has a number of social services that he or she interacts with. It's very important that you know, as that ER doctor, what those are, because that may affect how you're going to prescribe the care regimen. And so being able to surface that information and bring it into the technology and render it in a way that's meaningful to the practitioner is critical. And so that, I think those are the opportunities that present in social determinant. I think we see a lot of the social determinant analytics, especially in the risk-based world, where payers are using the social determinant data to be able to tell demographic profiles about the given patient population. Imagine that you're a managed care organization and you're taking on 15,000 new patients in your next month. Behoove you to understand what those patients are and how they interact with the system, both from a healthcare perspective and also from a social services perspective, so you can start to quantify and strategize how you're going to provide care for those new patients. So the social determinants is a super interesting conversation. I think it touches the spectrum of at a specific trigger, like I just talked about, all the way through what Heidi talked about being able to render some of that through mobile devices, through ways that allow people to interact with data completely differently.
And I think there's a lot of opportunity for exchange of information. Some of our information about social services that someone receives are in one, they're in Department of Children and Families information about, do you have housing and food stamps and assistance of this type or that type, combined with the Medicaid and information that a health plan may need to know to be sure that you get the care that you need, that especially in emergencies too. We're dealing with a lot of emergent storm situations here in Florida. So.
Absolutely. Did we have any other questions, Carrie, from the audience?
Yeah, we've got a question. Any insights on how healthcare data can be used to combat the opioid epidemic?
Oh.
Good question.
Dr. Phil, do you want to take that one?
Yeah, I just wrote an article. It's an article this week on opioid epidemic, and I'm shocked that 91 people every day in the United States die of opioid overdose, and 40% of those are prescription overdoses. And it's interesting how a mass casualty shooting incident gets all the attention, but opioid epidemic is many, many times worse than that. It's one of the things I talked about in the book MedRec is that we don't have a good way to track the prescription side, and even in the heroin side, 3/4 of the people that end up using heroin today start with prescription painkillers, and we have not done a very good job of tracking the appropriate use of opioids and knowing who's using them and are they being used for the appropriate indications, because that has been associated with an increase in use of prescription opioids, which is corresponded to an increase in use of heroin, which has become very inexpensive alternative for people when you cut off the prescription side of things. So it's a very bad loop, and with both HIEs and certainly medication monitoring, we can see trouble spots. And back in the day when I was in private practice in the 90s, I actually served as a medical director of a drug and alcohol detox unit, and it was very frustrating to know that there were people coming in with prescription abuse coming from actual doctor's offices, and yet not being able to identify where those doctor's offices were. We shouldn't be in that situation today. We should know who's prescribing them, what they're being prescribed for, and look for patterns which indicate aberrant behavior, both in prescribing and usage. And we need to intervene, because helping people get over addictions is a very difficult, timely, and costly task, and we need to do a better job to stem the tide of the epidemic.
Okay.
And there's a lot of promise, I think, with the prescription drug monitoring program and the data that we have, and encouraging providers to query that data before they prescribe, and also to kind of unlock that data so it's more readily available to providers at the point of care.
Jason, do you have any thoughts?
No, I agree both with the good doctor and Heidi. I think exposing the data that's in the PDMP is, I think, one of the critical elements of making part of this change.
Prescription drug monitoring.
Yeah, exactly. Yeah, exactly. And I think there's ways to, just like social determinants, there's ways to incorporate specific clinical triggers to be able to expose that information so that it's more applicable at the time of prescription, or you actually want it right before prescription. But being able to have that technical handshake is absolutely critical, and I think we'll continue to see an uptake in this.
Okay. I want to check and see if there are any other questions that we have in the queue, Carrie.
It doesn't look like there are any other questions at this time.
Okay.
But folks, feel free to type them in.
Wonderful. I do want to ask our panel if there are new technological innovations that you anticipate coming out over the next few years that will impact or improve healthcare.
Well, for me, remote patient monitoring and telehealth, to me, will have the most promise, and has a very low market penetration at this point. Less than 2% of people with chronic disease are currently being monitored remotely, and the prevalence of telehealth visits is growing in some markets and non-existent in other markets. And I know in the state of Florida, Nemours Children's Hospital in Orlando and in Jacksonville, they've been leaders in providing telehealth visits, which I think are a great opportunity for parents and their children to be able to conduct remote telehealth visits through video conferencing after hours with dedicated physicians. That's all they do. And I saw a little news clip today of a Google project. I don't know if it's fake news or not, but setting up clinics with manned by a nurse, where you could literally go in and be in front of a nurse who is then connected virtually to a physician, and leveraging physicians and shortage areas, and create these virtual clinics where they're actually walk-in clinics. And today, you know, I don't need a stethoscope. I can use a remote stethoscope. I can use a remote device to look at your ears. I can, you know, do a lot remotely and leverage my physical physician skills through telehealth and virtual monitoring that I couldn't do even 10 years ago. So I think the care delivery is going to be a great opportunity. And eventually we'll get to artificial intelligence, being able to better triage people and to keep the worried well out of the emergency room, because that would be another opportunity that could really cut healthcare costs, especially for our Medicaid population.
Heidi, did you want to add on to?
I'm just, you know, I try to focus on what we can leverage with sort of the policy leverage that we have at the state level. You know, paying attention to what's in the environment, what comes along, what we're able to promote, and you know, look towards adoption and do outreach. We're doing a study on health information exchange environment in Florida, and we're going to look at the landscape and the adoption both of interoperability as well as electronic health records. What are the barriers? What are any kind of policies or innovations that are opportunities, as well as things that we can overcome, and create a roadmap that's not just focused on the Medicaid program, but sort of across the Florida landscape. So I think that's a promising. That's not a technology exactly, but I think that's a promising look and a real opportunity for us to understand what's out there.
Heidi, what percentage of Florida physicians are actually connected to the HIE now?
That's, our primary service is the event notification service, and that all of the, I think we have 212 hospitals as data sources, and then the subscribers are primarily health plans and accountable care organizations, so they flow that information out to their primary care providers and their case managers. So it's not an apples to apples kind of question that I can answer. We are our patient query service. We're sort of leveraging the eHealth Exchange infrastructure. We have a lot of participants already connected to that, and we're going to be promoting what they call whitelisting, where they're connecting with one another rather than kind of recreating that infrastructure. And then the direct messaging, we do offer a mailbox service so that there can be an endpoint for providers on that. But I think a lot of providers have that embedded in their electronic health record, and Pam and her outreach activities kind of encourages them to find out what their address is, so they can connect with other providers. I'm sorry I didn't answer your question.
That's okay. And we are right at 2 o'clock, and so I do want to be cognizant of everybody's time, but I want to give Jason an opportunity, 30 seconds, to give us his thoughts on
all right,
what's coming
30
up.
30 seconds. Here we go, 30 seconds. I think from a health IT perspective and a data perspective, there was a thought about 10 years ago that if we centralized all the data, that people would come to the data source and interact with the data. And what we found over time is that's simply not true. What we're finding now as a trend is exposing this data, making it available, and delivering that data at a very specific point in the workflow. And so you're developing, instead of having this entire library of data, you're rendering only specific data elements that are very important to that practitioner or that administrator or that care team so that they can perform their function more effectively. I think we'll continue to see this as a trend across the industry. We see this through various mechanisms from a technology perspective, but we have a lot of, from the business and clinical side, a lot of folks asking for this. So I think that'll continue to be a trend as we go forward.
Wonderful. Thank you so much, Jason. And thank you to Dr. Phil Smith, Jason Mcnamara, and Heidi Fox for being our panelists today. If you're in the audience and you typed in a question and we didn't get to it, we will respond to your questions as best we can. We'll try to get input from our panelists and respond to your questions. And we appreciate your input, your questions that you asked to help make this virtual panel very enlightening and engaging. We hope you enjoyed it. If you want to listen to it again, it was being recorded, and so we'll post that so that you can share it with your colleagues and invite others to hear what's going on with health information and technology and what's on the horizon. We have contact information on the website or on the screen now, so hopefully you can get that. Again, that will be available online. Thank you again, panelists, and everyone have a wonderful day.